Hello, everyone. You are listening to the Autoinflammation Decoded and Beyond podcast, sponsored by FMF and AIDS Global Association. In each episode, we will focus on topics relevant to patients, physicians, and researchers interested in autoinflammatory and innate immune diseases. Thank you for joining us.
Hello, everyone, and welcome to the Autoinflammation and Beyond podcast. Today, we have the pleasure of speaking with a renowned international researcher, Professor Seth Masters, whose work has made both a significant and positive impact on those living with rare autoinflammatory disorders, which are diseases, many with genetic causation of the innate immune system. He currently leads the Center for Research Excellence in Autoinflammatory Research and is the head of the Center for Innate Immunity and Infectious Diseases at the Hudson Institute in Australia. Welcome, Professor Masters, and thank you for sharing your time with us.
Hi, Ellen. It's fantastic to be here.
So to start off our questions, I'm really curious, as are several other of our visitors, how you became interested in autoinflammation in the innate immune system, and what sort of led you into that space where it's not very well known, but it certainly plays the most important role in humans.
Absolutely. It was certainly an area that I didn't know much about. When I was doing my PhD, this is in around the year 2000, we were studying a totally unrelated protein. Essentially, I was working in a cancer biology laboratory. And this unrelated protein, it turned out during my PhD, we determined what it looked like structurally, and its shape and conformation. And it turned out that that particular part of that particular protein I was working on had the same shape and a very similar structure to the part of the protein which is called pyrin, encoded by a gene called MEFV, which is the gene that underlies the disease familial Mediterranean fever. So although during my PhD I didn't directly work on an autoinflammatory disease, it turned out that that structure that we solved was important for understanding where the different variants in the disease familial Mediterranean fever map to that particular protein. And so it was a total fluke that that link was able to be made. And based on that, I contacted after doing a PhD, it's often customary to do further training elsewhere. And so I did, after my PhD, a period of postdoctoral training with the people that I met during the time that I was working on that other protein that was similar to the familial Mediterranean fever protein. And they were, of course, some of the best known world experts in this area, principally Daniel Kastner and Ivona Aksentijevic at the National Institutes of Health. And so it was really fantastic. And that opportunity to train with them and learn a lot, really, for some of the main experts worldwide about these conditions.
Wow. So did you work at NIH proper, or did you just work as across seas? Because I know obviously you're located in Australia.
Yeah, no, so that required me spending 3 years in Bethesda at the NIH, and that was wonderful. And I think it's one of the amazing things about scientific research and the endeavor is that it really is a hugely collaborative thing that involves many researchers globally. And so often you do need to travel for periods of training to access knowledge and techniques that may exist only in small centers around the world. So actually, even after that, I did another 3 years over in Ireland, in Dublin, learning from fantastic experts in innate immunology there before coming back to Australia about 10 years ago.
Wow, that sounds fantastic. And tell us, we know that recently there's been a registry through the Australian networks to look for autoinflammation in Australia. And I know that with your new appointment at the research center. Maybe you could talk a little bit about how those two things, have worked for you. You see, you've come full circle after all those years away from home, working it in obviously a fantastic new endeavor. And then I guess with the registry, trying to find those patients that you need to help out, in the background of your research in genetics.
Precisely. So, on coming back to Australia and setting up my laboratory here, it was clear that we didn't have a centralized sort of place where autoinflammatory disease research and it was happening. And so it was an idea that formulated together with a clinician who came and did her PhD in my lab, Fiona Mogadas. We thought about setting up this registry to really do three things within Australia. The first thing is hopefully to capture some of the statistics around the numbers of patients and the types of diseases. Also, the types of treatments, the time to diagnosis, the basic fundamental statistics that drive our understanding of the disease incidence in Australia. I would say, however, that it's very challenging to capture those sort of numbers because within Australia, we don't have a centralized electronic registry for medical records. And so we do have to try and basically manually enter a lot of data into the database from, 40 or 50 sites around the country, which is a rather difficult logistic effort. And some of that is really helped out now by the Centre of Research Excellence that we've established. So being able to apply for and obtain funding to set up different streams like this. Previously, the registry has been largely unfunded. So we've had to do a lot of that data entry manually without a lot of financial backing. So it's wonderful to be able to have some input from the federal government to help spur these efforts. Coming back to the registry, so one aspect of it was the epidemiology of disease.
Sure.
A couple of other aspects that the registry can help out with. One is that I'm not a clinician, so really what we can provide most to help with is not the initial diagnosis of a condition which might happen perhaps within a hospital or a commercial provider of a genetic test. But where we can often help in a lot was where a genetic test turns out a variant of unknown significance, or a genetic test might say actually that nothing was found. And that actually happens reasonably frequently. And so most of the patients who get referred actually to us now tend to have a disease where it's been very hard to find what's been the underlying cause. And our genetic investigations can go a little bit further than what happens in routine practice in most of the commercial providers. And we can look actually for new, novel genes causing the disease. And that gives us an ability to really push the envelope in a research basis to find out what's happening. And we can also validate some variants of unknown significance. And we can take, hopefully, some of those variants and say either that they're benign or that they're pathogenic to try and help patients obtain a diagnosis. So that's where the research angle plays a really big role. And finally, the registry and our Centre of Research Excellence are supposed to be functioning as areas in which we can foster knowledge and awareness of the diseases in Australia and get clinicians talking to basic researchers and patients and patient advocates. And I'd like to shout out to Sharon Kensel and Karen Raymond, people who you may know, really active in this space and have been tremendously helpful in advocating for patients with autoinflammatory diseases within Australia and really helpful for us setting up these efforts. And so what we do every couple of years is we run a symposium in Australia. We have another one coming up actually in February 24th and 25th, I believe, off the top of my head, in Brisbane. We'll start sending out flyers for that shortly. And if people would like to attend, it's a really wonderful opportunity for basic researchers, clinicians, and patients and their families and supporters to come together and discuss these conditions and think about more that we can do to improve care moving forwards.
Yeah, I think that it's so essential that patients be a part of the research process. I think that medicine for a lot of years has really sort of missed out on that. And I also think for rare disease patients, there really aren't any choices because it's medically so far between what happens in the research in the lab setting and the important medical institutions down to a common, a typical rheumatologist who's trying to treat a patient and doesn't really have the understanding or even the knowledge because they were never taught that themselves in medical school. And of course, it puts the doctor at a huge advantage, not to mention I'm sure you've heard the patient stories of trying to find a doctor who would have an idea when they really need to go to a place where they have the science behind that to try and help organize or figure out what their disease is, especially, like you said, in some of the newer types of diseases, which we'll definitely, speak about a little bit. But it's always really important to have patients with their voices in this entire rare disease game so that they feel one heard and two that researchers themselves can have new ideas because it's not like it's in a vacuum. The patients have problems that are really odd and strange in some of these diseases that, may often go completely overlooked for years at a time until a researcher finds them and says, oh, and then it's like a light bulb for everyone that that is actually a clue of where to go and look for whatever, genetic malformation or immune problem that may not have, may have been either overlooked or just not really recognized as, in terms of genetics. We're certainly finding out a lot these days that genes play multiple roles in various diseases that was never, the old mantra, the gene does one thing, one pathway, and now all of a sudden it's opened up and it's just very complex, but probably quite exciting to somebody like you who's in this research game, and very interesting to keep your work, really interesting and quite engaging.
Yeah,
Um,
that's definitely true. And I can only, double down on what you've just said there and agree that it's so critical for us because these conditions are not common. Just awareness and knowledge is one of the things that's often missing from the conversation. And so for patients and their families to be informed is so, challenging, but really helpful for us as researchers and for clinicians as well. So I think getting us all together in the same room and talking the same language is ideal.
Yeah, quite key and quite critical. In terms of autoinflammation itself, maybe you want to talk a little bit to most of the people who will be listening to this probably have a somewhat basis for what autoinflammatory diseases are. But I know that through your work, and I've read several of your papers, that you have been involved with yourself and various teams across the globe, like you referred to. Um, Basically coming to understand several new diseases caused by genes that are atypical to the typical monogenic, the FMF, the CAPS. But maybe you could talk a little bit about your view of what autoinflammation, diseases are, and some of the newer ones that you've been involved in helping basically bring to light to the world and through the research.
Yeah, the one way to think about autoinflammatory diseases is basically very similar to autoimmune diseases, and so probably many of your listeners are familiar with the concept of our immune systems being turned on to fight infection and things like that. And in an autoimmune condition, it's really those adaptive responses that are supposed to learn how to fight viruses and bacteria over a long period of time that are turned on, and you get these antibody responses that are really characteristic there of autoimmune diseases. Now, in the case of the autoinflammatory diseases, it's not a longer term adaptive learning process that is turned on your immune system. It's this other part of the immune system called the innate arm of the immune system. Those are the responses that are really fast and rapid, like when you get an infected cut and there's pus at the site. It's really the cells that are there to gobble up bacteria and viruses and immediately quell that infestation. So when those pathways are turned on, that can be quite a severe inflammatory reaction, with fevers and rash and redness and swelling. Those are the inflammatory markers of an innate immune response. And indeed, what turned out to be the case is that, although not all cases of autoinflammatory disease do have a genetic basis, some do. And when we found those monogenic cases, they turned out to be in genes that activated or were part of the innate immune system. And so it really made a lot of sense. Some of the ones that we've been doing the research on have been genes like, well, perhaps one of the first ones that I was involved with when I went to the National Institutes of Health was a gene that many people would sort of know of, interleukin-1. That is a profoundly inflammatory gene, the interleukin-1 beta signaling cytokine. And we found that there was an endogenous, like a protein that exists in all of us, that is a negative regulator called the interleukin-1 receptor antagonist. Now, it turned out that that is actually a drug that many of your listeners might know of called anakinra. So that molecule that exists in all of us is actually something that has been turned into a drug and can be used to block IL-1 signaling and to provide benefit in some cases. Now, what we found when I went to the NIH, and this was amazing work from Rafaela Goldbach-Mansky and Ivona as well, was patients who, unlike most people, who had mutations, who lost their endogenous interleukin-1 receptor antagonist. So they didn't have that molecule in their bodies. They didn't have that break on the inflammatory signaling. And so that created a very severe early onset autoinflammatory disease. And wonderfully, because the genetics pointed to the mutations and we knew the protein that was missing was a drug that we could give to the patients, that's what happened. And then they got much better because, of course, the exact protein that was missing from their bodies was able to be put back in again. So it really had very, very good beneficial effects. So that was one of the first of these conditions that we've sort of been involved with. And then there's been a number of others since then. One of them actually being the one that I sort of first mentioned to you, MEFV, the gene that underlies familial Mediterranean fever. And while historically that had been considered to be a disease that was recessively inherited, which means that both parents have one copy of the gene variant, and then the affected individual, the child of theirs, has two copies of the variant, and only then does someone get the disease. Actually, what we found was that there, in some cases, are evidence for a single gene change causing a disease like FMF. But actually, it turns out to be a spectrum of disease. And I think this is something you mentioned earlier as well. It's no longer really just one gene does one thing. And sometimes the spectrum of disease that comes from one gene can be quite broad. And in this case, we gave the disease a slightly different name of pyrin-associated autoinflammation with neutrophilic dermatosis, which is a mouthful. And the reason that we gave it that complicated name was to help explain that you could, in fact, see a disease which did not look exactly like FMF, but the underlying basis, the protein that was changed and the gene that was mutated was the same one. And therefore, thinking about targeting that in the same way was possible in terms of therapeutics.
I mean, that is so, yeah, I mean, that's really interesting, because one of the issues that we have seen for a lot of years with the patients is that we'll often come across those who are really sick, have been genetically tested, and are basically told, you only are a half carrier. Basically, you've only inherited this one mutation from mom or dad. And if they've tested the family, they have definitive answer on that. But then the patient is then said, oh, well, I'm sick, and they clinically meet some of the criteria, or they have symptoms similar to that criteria, but maybe they have some added rashes, or like you referred to, the neutrophil infiltrate in the skin. And all of a sudden we're not quite sure what we're seeing here, but if it's only one gene or one heterozygous mutation inherited, then what? And then that is another whole struggle beyond just knowing what an autoinflammatory disease is, but the struggle then for the physicians who actually deal with these diseases, but they're told, oh, you have to have this. And I don't think this is just to autoinflammatory diseases. I think this is to many rare diseases where they said, well, if you're inheriting only one side, you cannot possibly express with this disease. And it's been kind of crazy. Like I said, the last few years of research is starting to show that that is in fact not even anywhere close to what is actually happening in some of these patients, much less the carrier status of often genes that affect only men, and they're told, well, the women don't really have any of those symptoms, and now they're finding out from all those mothers that in fact they don't have full disease, but they have something that's not quite right. So I think that is just absolutely kind of mind blowing in itself. So, and I
Yeah,
think that's really important too, because the other part of that is the compounded heterozygote type of case where you've got patients who inherit mutations, and some of them aren't always considered to be pathogenic. Some of them are definitely, well, I have one benign, one pathogenic, one VUS, and that whole status of the gene, as everybody knows, is a real hard sell, because some populations are one way, other populations, that gene would always be negative or benign. So that whole process is quite in the works. But when you get these patients who have like two or three mutations, well, you only have one, but then the patient really doesn't. And then what do you do? And is it the same expression of disease that you would see in a full-blown patient who has homozygous for the most common mutation, say in the MEFV? And it just leaves for even more, as I say, kind of ghosting, because, you see the symptoms, then you don't see the symptoms. And it's like, how do we define that? And it's really confusing for a lot of patients as well as physicians to kind of sort that out.
Yeah.
And I would imagine.
This is one of the things that keeps us really busy as researchers, because a lot of the time when there's an unusual incidence of a case where a disease might really look like a particular rare autoinflammatory disease and have a variant in the same gene, but it's the wrong inheritance pattern, like dominant instead of recessive, or it's in the wrong part of the protein. But what it turns out is that a lot of the time when we do the research, we're able to come up with reasons why it does look like that. So there's obviously there's a lot of complexity and a lot of detail in that, and it's different for every gene. But it is quite possible with the resources to do that research and to try and work out what is going on in some of those compound heterozygous cases or unusual inheritance patterns of disease. So it's really important not to ignore those sorts of findings and to think really hard about what the explanations could be. And as much as possible, we're really working hard to turn, every VUS into something that we know something about. If we could say a little bit more, then that means more power to patients to be able to make a call on what their disease status is likely to be. But I would say that some of this is going to be really hard. So, there are examples where, we've got 20,000 genes in our body, and we know that 40 or 50 of them can relate to autoinflammatory disease. But how many are we missing? Probably a few. And so you could even have cases where patients have one variant in one gene, which normally doesn't cause disease, but they have another variant in another gene, and together they do. And if we don't know about those sort of cases, these sort of digenic or even multigenic inheritance of disease, it's going to be really hard to work it out. But the future's bright. I think, we have a lot of modern technology that's being applied to these sort of cases. And with genetics, we have amazing data sets to analyze. So I'm hopeful that we're going to get more information as the years progress. And there's already been amazing progress so far. So, I think the future's pretty bright.
And that kind of leads me to ask sort of to talk about another whole issue in this genetic genetics aside, if you will, is that the measurement of these diseases and the inflammation, and I know we're going to talk a little bit about the inflammasome because you've done a lot of work in that area. But one of the things that's always of concern when we're looking at various patients and they come to us looking for help and, direction to where to go, is that they talk about this retesting over and over in these diseases for essential criteria of having an elevated CRP, an elevated SAA, which that test is not available in the United States, or an elevated ESR in some cases. And we have patients all over the place who try to get the blood test and they're shown, okay, the CRP is highly elevated. We know this is autoinflammatory. And then there's other cases where the patient, well, it's not captured, or I don't have a blood test, write up so I can go to the lab at a certain time when I'm really sick so that they can try to capture this. And one of the things that is really concerning on all ends of this is how do you best capture that? And what happens if you're mutated in those genes that would even cause your CRP to elevate? I mean, we know C-reactive protein is so common when they're looking at heart attacks and other types of inflammation, but it seems to be the catch-all for autoinflammatory diagnosis, and especially with doctors like we've talked about who are not highly trained in this area. The premise is, doesn't matter if the patient has fevers or these GI manifestations or joint pain, but it's all about, we've got to have your lab. We're going to treat you as a lab. And if that CRP doesn't come back high enough, and that's another whole thing, because we have people who have they'll be elevated 10 points over. Well, that's not too much, but it's still not normal. And if you were having a heart attack in the ER, they would be like, okay, we have a problem here. And then they'd go right on to look at your troponin and other, cardiac enzymes that are, critical to making sure the patient is not having a heart attack. And I think that that is another whole area that we have struggled with in trying to figure out, what do you do with that? And what happens also when you're, an SAA gene itself, that can be modified through whatever process and family history you have. And that too may be really normal. Or in the other hand, it may be so high that doctors are like, well, we have to redo this test because it couldn't be possible that that you would have an 800 on your lab report. That must be a mistake. So I think that is another, the genetics part is extremely complex, but then it's also the markers of the disease also seem to be not so much complex as they are very confusing as to what it really means to have no elevation, mild elevation, complete lack of elevation. And we know a little bit that there is at least there's got to be genetics there that may be a contributing factor to not having those levels, much less maybe some of those genes actually are contributing to disease process and nobody even knows about that yet, because like you said, there's thousands of genes to look at, and where do we go with all of that? So maybe you can make a quick comment about that too, because we try to say clinical presentation is so much more important than a laboratory test, because you still need treatment and help despite those numbers being too high, not high enough, et cetera, et cetera.
Yeah, it's true that in terms of biomarkers, we're still fairly limited in this space. I think it is important to think about elevations of CRP and where available SAA and these other markers, because it's SAA that's really the one that could be problematic if amyloid builds up over a long period of repeated fevers, for example. Then that can be deleterious. And so keeping inflammation under control, I think, is the aim for a lot of therapeutic intervention. The other reason that biomarkers can be important is if it points towards a particular therapeutic approach, like a biological, for example, or if it's going to be a case of diagnosing FMF or colchicine might be effective. So do we have great biomarkers to sort of indicate what type of autoinflammatory disease it might be? Well, not great, but they're starting to get better. So in terms of actually one that works really well, but there's not so many cases, are these interferonopathies, which are a branch of the autoinflammatory diseases driven by type 1 interferon. Now, this is a number of ways of working out how high that pathway, how much that pathway is being activated. But an interferon score is one of those ways. So instead of measuring the cytokine, the inflammatory protein itself, the interferon, type 1 interferon itself, you can measure the downstream products that it induces, the signature, if you will, of the presence of that inflammatory pathway. And that's something that we and others can offer in a research setting as a good way of determining if that particular pathway is upregulated. And there are drugs that block the signaling through the type 1 interferon receptor, the JAK inhibitors, and so they can be quite effective in cases where the interferon score is elevated. So that's a good thing to know, that the biomarkers there work pretty well. But for cases where the autoinflammatory disease might be driven by the inflammasome, for example, we do struggle a little bit. And that's because the cytokines, the inflammatory proteins made by that protein complex, interleukin-1 and interleukin-18, interleukin-1 is just really, really low. It's this tremendously powerful molecule, and even a tiny bit of it is really inflammatory. And so the amounts that are in the circulation to cause really severe disease is just actually not that much. And so it's just hard to detect. And so, that's one of those problems that I hope that modern medical research can solve, because it's a question. It's just one of those, it's just a technical hurdle that we need to cross. And so I'm hopeful that newer technologies and ways of measuring that cytokine and the process of inflammasome activation will come to bear. It turns out that interleukin-18, you can actually measure the free amount of the IL-18, and that's a relatively useful assay in the case of systemic onset JIA and macrophage activation syndrome. So there is some utility there, but it unfortunately doesn't play out too much more broadly within the autoinflammatory diseases, although maybe PAPA syndrome, where there are mutations in the gene PSDPRP1, is another good example where the free IL-18 could be helpful in diagnostics.
Yeah, it's also very interesting because we always recommend, in parts of Europe, it's much more common than the United States to have a cytokine panel to see what cytokines are elevated. And of course, with the reminder that your IL-1 could be completely normal and you can have other cytokines that are elevated, and you can still have a full-blown autoinflammatory, genetically, identified disease. And it's just really interesting because I'm assuming, with my limited knowledge of the inflammasome, that, like you said, the different ways they kind of come together leads to different pathways, and not everybody's is going to be the same, probably within a given disease. I don't know what, and research has gone on with that, but maybe you could talk real briefly about what the inflammasome is, because you have done studies on this, and this is sort of a newer take on the whole disease process, because I know that the idea was basically, it came to fruition, 2 decades ago, almost 2 decades ago. But, as you know, science can move very slowly in people studying these things, along with trying to get money to study them. But it seems now the last, 2, 3, maybe 5 years, it's everything inflammasome. And they have so many medical meetings and technical people all over the place now looking at the importance of this. Could you maybe just give us a little bit of definition of what the inflammasome is, and how does it work in the body? And I have been told too that inflammasomes might work differently in the skin versus the organs versus other parts. It's really fascinating.
Yeah, absolutely. The inflammasome, essentially, we've been talking about these inflammatory cytokines and the things that get secreted out of cells to cause inflammation as they float around in your body. So most of these inflammatory proteins, they've got a little, it's called a leader sequence, a little bit of their code at the very start, which says, hi, I'm a little inflammatory protein, and it tells the cell, hey, just shoot me out into the circulation. But there was 2 cytokines, interleukin-1 beta and interleukin-18, which I already mentioned, and they did not have that little bit of information to explain how they got out of the cell. But of course, they must, because they were profoundly inflammatory and could be detected in the circulation. So that's the job of the inflammasome. It's this complex of proteins in the cell, and it exists to cleave and activate interleukin-1 and interleukin-18, and it punches little holes in the membrane of the cell to let the interleukin-1 and the interleukin-18 out. So that's the job of the inflammasome. And as you've mentioned, there are many different sort of immune sensors that can form inflammasome complexes. It's not always the same inflammasome. So depending on probably different types of infection is why we have different inflammasomes. There's different inflammasomes set to detect viruses or bacteria of different types. But probably in most cases of autoinflammatory disease, it's being actually those inflammasomes are being activated by different disturbances. Mutations or breakdowns in cellular homeostasis in different parts of the body. And so some examples of things that can form inflammasomes are the pyrin protein that we mentioned earlier that underlies the disease familiar Mediterranean fever. There's also NLRP3, which is probably well known to some of your audience, underlying the disease CAPS. And that's part of the main reason why inflammasomes are so, hot right now, if you want to put it like that. There's so much research going on, is because inhibitors, specific small molecule inhibitors of NLRP3, have been generated. And although they're not currently available for clinical use, they are in clinical trials. And that leads a lot of hope that we can, as a medical research community, not only generate inhibitors of NLRP3, but also perhaps other inflammasomes, like there are other ones like NLRP1, which is expressed more in the skin. And indeed, if you have mutations in NLRP1, that can cause a disease associated with various inflammatory skin lesions. And NLRC4, which is expressed in the gastrointestinal tract and can lead to very severe early onset gastrointestinal inflammatory disease. So the location of these different protein complexes in your different tissues and parts of your body helps explain a couple of things. One, why you might experience different symptoms due to different pathways being turned on. And two, coming back to our discussion around biomarkers, why you might have trouble detecting when these things are turned on, if it's creating inflammation in a particular site, and then the only way you find the biomarker is by looking in the circulation of the blood, well, you might just miss it if you're not looking in the right place at the right time. So it does make it challenging to find out where and when these things are activating and some precision medicine.
Yeah, it's quite interesting that the possibilities that in terms of measuring all these things. I mean, certainly you can't biopsy and blood draw the person until they fall over. But I mean, it's just really fascinating how different parts of the body, throw off inflammation. And, it's a clinical presentation for most that, it's not always going to be captured very well. And that's another, like we talked about, another area where there's a lot of concern, because if you're having the clinical symptoms, you have to be able to communicate that effectively to your physician. And, sometimes patients don't even realize that a symptom they might be having, of a bad rash or something that only comes and goes very infrequently, might be a problem. That to report that in, to make sure that it's at least captured by the physician in their notes, so that they can understand, hey, there might be something going on that we're missing that is maybe a topical presentation.
It's a really broad spectrum, isn't it? And
Yep.
It's really important to really think of everything that could be possibly associated with that, because it can sometimes be some of the more unusual things, or the less common things that you'd think would be unrelated, which turn out to be the thing which is, that's the thing that turns out to be the more differentiating factor, which goes in a particular direction than something else.
Yeah, that's why we always say to patients, symptom diary, record everything, take photos, even if the rash only lasts 5 hours, because that could be one of your keys to, maybe getting figured out, genetically or otherwise, if it hasn't been done already, to say, oh, well, this is something new. And if you can meet the right research or the right doctor or the institute, wherever you might go, oh, that might be a big solid clue for somebody to go in a completely different direction to try and figure out what is wrong with the patient. Speaking of going back to the genetics real quickly, I thought maybe we could sort of, I know you've got limited time and all, but One of the things that we see with patients when they get genetic testing is that we always tell them, get your full benign list and let's check everything against Infevers, which I know you are play a role in. And I thought it might be great because nobody ever really talks about Infevers unless you're in research, but maybe to tell patients, what is Infevers basically? And it's such a great model. I mean, I have suggested to other specialties, this is a great model for following genetics. And there are so many other diseases that have multiple genetics being discovered. It's a great way for not only researchers, but doctors to go and check in Infevers to see what may be amiss with their patient. But if you could maybe just talk about what it is and how your role working on that is playing out for, autoinflammatory genetics.
Yeah, Infevers was really, really important for many, many years, really, even since we only understood one or two genes underlying different autoinflammatory diseases. That was the place where essentially every single variant that could cause the disease or was in that gene was listed. And so it became invaluable as the number of variants identified greatly exploded as genetic testing increased, to be able to find out, well, does somebody else have this disease with the same variant? And so that's the resource, that's the place to go to say, has this been seen before? Did it cause the disease? It is being very well built upon by ClinVar, another very large international resource. And these are basically large international databases or registries that accumulate all of the gene variants in specific genes. So for Infevers, it's specific to autoinflammatory diseases. For ClinVar, they're doing every single Mendelian sort of gene, all gene variants. But they really do list the vast array of variants that are out there. And, as important as the ones that contribute to disease are, there's those that turn up that are present but probably benign. And they're really important to know about as well, because we don't want people mistakenly thinking they have one condition when in fact they might have another one that they need appropriate treatment for. So, really taking on board whether the information is that it's benign or pathogenic or somewhere in between these variants of unknown significance is probably really important. But just to mention that some of these variants of unknown significance fall into a really difficult category, which is they might be risk factors, so that they're not by themselves going to cause the disease. And they're not totally benign, so that they can be found in healthy individuals, but they provide some level of risk, we don't know how much, for the incidence of the disease. As a community, I think we still struggle with how to manage those risk factors. There's not too many of them out there, so we don't have to be aware of too many of these, but I think there are going to be increasingly something to be aware of that clinicians sort of need to take into consideration, that although it may not by itself be causing the disease, it could be something which is part of the disease etiology. And so how that plays into diagnosis and therapy is very challenging, but something that needs to be talked about and considered.
If you are a physician and you have a patient who suddenly, you get genetic tested and they sort of fulfill some of these criteria, how should doctors go about reporting or making sure that if they have an autoinflammatory like patient that they suspect has something that has not been seen before, what do they do to go about reporting that to the appropriate people at Infevers to make sure that their patient is being, counted towards this, or to, maybe it hasn't been seen before, but, oh, this is important. We need to let, the researcher in this particular area know that, this actually may be a new disease or a new mutation for it, an existing known disease.
Right. So if that's what's so important, is that if people do find things, to try and make others aware so that people can learn from that in the future and not have the same diagnostic odysseys that others might face in the future. If, and it's really powerful if there's two cases with the same variant causing the same disease, much more powerful to understand that than if there's only one. And so the different ways of making that, match are, principally to go through something like Infevers. And yeah, you mentioned that I have a role as an editor for variants in NLRP1. If anyone sees a variant in NLRP1, for example, they can log on to Infevers and very quickly and easily input a little bit of information about the gene variant, the type of patient, symptoms that are associated with that variant. And that can be really informative in the future if anyone else sees the same variant associated with the same symptoms. So, really encourage clinicians out there to consider spending the time to upload their variants into Infevers. It's slightly different when it's a totally new gene. Then you need to make a match on Gene Matcher, or otherwise contact someone like me or someone else in the community. There's a lot of amazing researchers and clinicians and geneticists all throughout Europe and America and in other places as well. So researched through the FMF and AID Global Association. They are people who have a lot of these contacts and try and get that linkage to try and improve the chances of a diagnosis for other patients in the future.
Yeah, we do come across that quite often, where we've got a patient who looks to be autoinflammatory, has mutations that are either not listed or there's no listing. There may be listing in like the LOVD database or some other place, but there's nothing in Infevers. And we always try to recommend that their doctors get in touch with a research institute in their particular country, because that could be, de novo, newfound something that it is really important to report on, because as you just said, the more reporting and the higher number of cases will lead to, new exploration or identification of, the disease or other factors of a known disease. It is really important. As we sort of close off on this, I thought maybe one thing to finally ask you. So for a long time, autoinflammatory diseases were considered to be sort of singular in their own space. They were not related to any other defects. That is basically the disease you were unfortunately born with. And in the last, I would say, 3 years, there has started to be this whole changeover in the world of autoinflammation that is linking these diseases much further than I think maybe research or doctors or the people who really are on the front lines of it realize that there is a seemingly huge overlap into primary immunodeficiency disease, lymphoproliferative disorders or blood diseases, and my favorite topic, allergic diseases, rare allergic diseases, eosinophilic mastocytosis. And it's really amazing because it seems like there may be some sharing of symptoms. It may all not be from a singular gene causing this, but it just seems like now in the whole world of autoinflammation that all of a sudden there's this whole scale of, we've got patients who may have multiple things going on. And maybe it started with an innate dysfunction, but then it carried over into sort of the other genetics of the person, no matter what they are, or turned on something that they were maybe genetically enhanced with through their family tree. And I just thought maybe in closing you could talk a little bit about this, because we have constantly said to patients, it is so important that if you have reoccurring infections, or if you have a lot of allergic type of issues, and I don't mean just, seasonal allergy, I mean like serious problems, that you need to be investigated for a whole variety of things, because it could be that your innate immune system was so deactivated or defective that your adaptive immune system is really, really impacted by these diseases. And that's a hard thing too, because people who study adaptive immunity don't always think of innate immunity. And the innate immune people are like, well, we were here first, and we're like the basis for everything on the human. And it's just been really interesting, but kind of scary, because we spend a lot of time saying to patients, you have to get further help, because even if you're on colchicine, but you're having repeated infections or you're having serious issues eating, there's something else going on here. And that's not all patients. Some patients fit the criteria, take the medications, do very well, but a lot of patients do not. And it is it is a top priority to try and help those patients understand and then go and try to access further help.
Initially, you're absolutely right. The classification, the way that it was proposed that autoinflammatory diseases would work would be, relatively simplistic. It would just be activation of the innate immune system, and we wouldn't see a lot of the complexity that you sort of outlined going on. But I guess that was more about differentiating autoinflammatory diseases from autoimmune diseases. And I think that's been really important and really successful because we're still talking about autoinflammatory diseases and understanding them and treating them in a very different way to autoimmune diseases after, 20 years or so. So it's been really important for also thinking just about the rubric of, what is an autoinflammatory disease. And, case in point, when the original moniker of autoinflammatory diseases was proposed by Daniel Kastner and Mike McDermott, I think they were sort of saying, well, what sort of diseases could we think about without knowing, how it would relate? And they sort of proposed gout as one of these highly innate immune-driven diseases. And that was before we knew that you could actually have in gout activation of the inflammasome. And so it really helps to understand why just thinking about the disease and the presentation of the condition and how it fits into the rubric of autoinflammation. And then later on, it turns out to be true at a molecular level. So it really it fulfills the criteria of being a useful organizational method. And then the inevitable complexity that you outlined in terms of, which we probably predicted because it was well known that the innate immune system could drive the adaptive immune system. And so that's something that we had expected to play out, although probably it plays out less frequently than we'd expect. And more frequently, what we see is the other things you mentioned, that you can have both your innate immune system turned on, but also some of your other cells, like adaptive cells, not working that well. And so you have repeated infections, or you have allergy or asthma. And so that turns out to be something that occurs, as well. And the mechanisms for that are complicated, but it really boils down to a lot of these pathways operating differently in different cells at different times. I guess I mentioned to you that we've got 20,000 genes, and it sounds like a lot, but hey, we're pretty complex organisms. So to be able to do that with only 20,000 genes is an amazing feat. And so often these proteins and these genes are doing many different things in many different cell types. And so you can, in fact, of course, turn on your innate immune system and have huge amounts of inflammation, but also at the same time, that same gene defect can lead to alterations and inappropriate neutrophil responses or adaptive immune responses and infection. And so that leads to quite the treatment quandary in terms of blocking inflammation, because that should work to keep some things under effect, but could be quite bad for infections and other things like that. So it does make things quite challenging, but the more we know about and have experience with identified cases, and that knowledge can be disseminated, the better chance there is for more improved therapy for other patients moving forward. So we are, the research community and clinicians are making huge strides hand in hand with your patients and patient organizations. So it's really great to see.
Well, I appreciate your information. Is there anything else you think that is important to add to all of this before we leave?
No, that's wonderful. Thanks so much for having me on.
I really appreciate your help, and talking about this subject is really great so that more people and more physicians can try to understand what autoinflammation is and how it works in the body. And hopefully we'll be able to, coalesce more patients into better care with better treatments in the future as time goes on. So we thank you so much for your work and contribution to this group of patients and to these diseases. And we look forward, of course, to reading more of your research and learning what other possibilities may exist. So thank you so much for joining us today. I appreciate it.
Thanks, Ellen.
Thank you.
Thank you for tuning in to the Autoinflammation Decoded and Beyond podcast. I hope you found today's episode informative and engaging. If you enjoyed the discussion, please subscribe, leave a review, and share it with others who might benefit. For more information, visit our website at fmfbandaid.org. Stay connected, stay informed, and we will see you in the next episode.